Good morning, everybody. My name is Yusuf Shamu. I'm the Vice Provost for Research for Rice University. Welcome this morning. It is my great privilege to welcome Congressman Dan Crenshaw to Rice University today for the third annual Healthcare Innovation Summit. Congressman Crenshaw has been a tireless supporter for the translation of biomedical research from the benchtop to the bedside. His passion for advanced and effective medical innovation stems from his own personal experiences as a young man. Dan's leadership in healthcare on the Energy and Commerce Committee is critical to our vision for making Houston a leading biomedical innovation hub. Today, you will see examples of companies bringing the best ideas from places like the Texas Medical Center directly to the improvement of patient care. New technologies and therapies are drivers for improved healthcare. Look no further than the latest generation of mRNA vaccines that have blunted the rise of COVID-19 in our nation. These revolutionary technologies did not happen overnight or in a few months, but were the result of years of tireless biomedical innovation in private companies, big and small, and in universities and national laboratories. And there is so much potential yet within the Texas Medical Center that we have not tapped yet. With the construction of the Houston Innovation District in Midtown and the TMC-3 just south of our current location, we are poised to become the nation's leading biomedical innovation and commercialization center. I think that all the pieces are coming into place, but we have a long way to go, and that is why the support of Congressman Crenshaw, city leaders, the mayor, and all the partners in the Texas Medical Center, including the academic partners like Rice University and the University of Houston, are so important. Together, we can build a biomedical innovation ecosystem that can take the best ideas from across the street and further equip our doctors and healthcare professionals in saving lives and improving the quality of life. Not only are new treatments and medicines critical for the well-being of our people, they are critical to the well-being of our city and its economy. The development of a robust biomedical ecosystem will produce new small businesses and train the next generation of healthcare workers in cutting-edge technologies. We will build a sustainable future and a beautifully expert workforce to serve it. We know Houston is the energy capital of the world. With the world's largest medical center and the dynamism of our city, we are primed to be an accelerator for medical care and innovation as well. I see no reason why Houston could not be for medicine what we are for energy. It's really up to us. The pieces are coming into place, and I'm very optimistic about our future. We have such potential in this city that I think is yet to be really tapped into and built in a way that helps not just Houston and Texas, but the United States and the world in general. So thank you very much. Welcome to Rice University, Congressman Crenshaw. It's a pleasure to have you here.
Great. Thank you, Yusuf. Thank you all. Welcome again to Rice. We want to give you a double welcome. This is actually the first large event we've had here since the world shut down in 2020. So thank you for coming. It's so good to actually see three-dimensional faces. So I am glad that you all are here. My job is very easy. I just want to introduce Congressman Crenshaw. The last time we actually got together was for the Healthcare Summit in February 2020. So this is a great kickoff for us to come back physically. So please join me in welcoming Congressman Dan Crenshaw.
Well, thank you, both Paul and Dr. Shamu, for that kind introduction. Your team at Rice University is great, and thank you for hosting us once again. Thank you all for showing up today. Really appreciate it. We'll have a good program for you. Promise you that. So this is the third annual Healthcare Innovation Summit. It's great to see all of you here again, and I can't wait to introduce you to some incredible people who are working on innovation in healthcare and here in America. And for the third year in a row, we're here to celebrate something inherent to our country, the spirit to discover, innovate, and create. Last year, when we held this summit at the end of February, the world was about to change completely. The global pandemic was already making its way around the world. And while we were here celebrating the kind of healthcare innovation that is only possible here in America, little did we know that we would be relying on that very innovation in the months to come to save American lives and livelihoods. Operation Warp Speed, spearheaded by the Trump administration, was a game changer. We took the arduous drug approval process that normally takes a decade before a vaccine comes to market, and we streamlined it with amazing, unprecedented success. Without compromising safety or efficacy, we were able to produce multiple vaccines in less than 12 months. And I see we have here Deputy Secretary Hargan, and I know he was a big part of that as well, so thank you. Deputy Secretary at HHS, by the way. Thank you, Dr. Hargan. The United States actually had 400 companies working on treatments and potential cures for the coronavirus, and 354 of those companies are small biotech startups who rarely get credit for the effort they regularly pour into developing the next generation of cures here in the United States. And America was alone in this regard. The only other country that came close to matching American innovation was China, with 46 different companies working on a treatment or cure. And because of American innovators and Operation Warp Speed, we are well on our way to the end of the pandemic and a return to normalcy. All this underscores a broader point that has been a priority for me in Congress. We must protect the free enterprise system, an ecosystem that serves as the incubator for healthcare innovation. Without it, American companies would not have had the framework, much less the incentive, to develop a vaccine in record time. Now, many rightfully bemoan the rising costs of drugs and healthcare in general. Unfortunately, that frustration and that emotion leads to careless and emotional policy ideas, which would upend the ecosystem in which innovation thrives. Price controls and a government takeover of our healthcare system would drive innovation out of America and probably into the welcoming arms of China. We would produce fewer treatments, not just for once-in-a-lifetime pandemics, but for cancer and Alzheimer's, and the countless diseases people around the world are living with. There'd be fewer doctors, fewer clinics, and therefore longer wait times and diminished quality of care. This doesn't mean we can't agree on the end goals. We need to lower the cost of drugs, and people need access to quality care regardless of their socioeconomic status. Where we differ strongly is the how. So how do we get there? What is the vision for how healthcare should work in America? What are the policies we need to enact to achieve that vision? So I'm going to lay out a vision today. I'm going to test it on you guys. And we're going to call it the Patient Empowerment Plan. Not settled on that name yet. Again, you can like give me feedback on that if you want. Patient Empowerment Plan, Patient Empowerment Vision. But the point is patient empowerment. First and foremost, we need to empower people. Empowerment means choice, which means competition. There's also dignity in owning your own choices in healthcare. This leads to the second goal, lowering costs. And the only forces that lower costs while still improving upon quality are market forces: choice, competition, patent protection, and of course, price transparency. Because a patient can't be empowered to make a choice if they don't know what things cost. So this fundamental truth about market forces is a hard reality, and it's one that Medicare for All advocates refuse to acknowledge. Third, healthcare needs to be modern, personalized, and agile. You should be able to FaceTime your doctor, use a simple app to choose a primary care physician in your area, and find an insurance plan that actually fits your needs. These are some guiding principles, not the plan yet. So how do we get there? What is the plan? First, we need to put healthcare dollars in the pockets of patients, not the federal government. When people are hungry, okay, we like that. So when people are hungry or in poverty, they can't afford food, we don't tell them, go to the grocery store, pick out whatever you want, the cashier will bill some third party and you don't know how much it costs. That would be a really weird way to deliver food. But we all agree that people need food. We should agree that people need health care. So we don't give the money to the government to decide how to feed people, to produce it and distribute it. We give people the money in the form of a voucher, a food stamp, and they can spend it on the food that suits their needs and the needs of their families. The same should be true for health care. A safety net that also utilizes market forces. To empower the patient, you must empower them financially. Instead of subsidizing insurance plans through Obamacare, committing to endless and unsustainable spending on Medicaid, we should transition to a different kind of premium support model wherein uninsured patients who can't afford increasingly expensive plans are directly subsidized through their health savings accounts. Getting there is not easy, I said it very simply, but getting there is not easy. But it's about time we lay out a simple goal so that we at least know what the end goal is and where we're trying to get to. So that's it. Now, one of the first concrete steps, I believe, is empowerment in the primary care space. Your primary care physician is your healthcare quarterback. But not enough people feel like they have a real relationship with a doctor. So that's why I'm pushing for legislation to vastly expand the direct primary care system and model. The idea is pretty simple. You should have a simple and affordable monthly fee for a primary care doctor without extra charges for visits and without third-party insurance. You're going to get a lot more detail on this later in the program. So this is exactly what Americans want in their health care: control over their health decisions with a trusted doctor of their choice. This model is already successful here in Texas, and it's time to accelerate that growth by simply allowing people to use their health savings accounts for direct primary care. For at-need communities, my bill gives states the flexibility to provide direct primary care to low-income Medicaid recipients. And to address the shortage of direct primary care in rural areas, my bill allows for national loan repayment programs to be available for direct primary care clinics in areas with a shortage of primary care providers. Another concrete step is regarding drug prices. To lower costs, especially at the pharmacy counter, we need to increase competition and close the loopholes that some companies use to game the system. That's why I helped introduce the Lower Cost, More Cures Act. That's H.R. 19. This bipartisan bill encourages innovation, promotes affordability of cures, and stops pharmaceutical companies from engaging in unfair, uncompetitive practices. Among many provisions is prohibiting the pay-for-delay agreements, for instance, that pharmaceutical companies often strike with generic competitors to prevent lower-cost alternatives from entering the market. It creates the first ever cap on out-of-pocket expenses in Medicare Part D, and a monthly cap for Medicare beneficiaries with high drug costs to help evenly distribute expenses across the year, among many other things. It also engages in price transparency, and price transparency is crucial to improving our healthcare system. You pull up an app on your phone to choose the lowest cost flight option, hotel room, or dinner reservation, and I want healthcare to be treated the same way. These are just a few of the ideas, a long list of solutions that are required to reach our ultimate vision to empower the patient. But at the heart of our nation's healthcare solutions will be innovation. That's what we're here about today. Innovation is what will ultimately save lives and drive down costs. You're going to hear from people today who embody that spirit of healthcare innovation. You're going to hear from people like Daniel Powell, who is developing new ways to treat opioid withdrawal and addiction. And people like Dr. Rick Doblin, who is researching how to use psychedelic therapy to treat drug addiction and PTSD. Dr. Glenn Davis, who's at the forefront of innovation in the direct primary care space, and Lisa Forbes-Satter, who has achieved a breakthrough in treating diabetes using precision medicine. All of our guests have devoted themselves to achieving a very simple but profound goal: delivering hope to patients. Because that's ultimately what today is about, delivering hope to patients through innovation. One patient who was a recipient of that kind of hope only American medical innovation and ingenuity can provide, was my mom, Susan Crenshaw. My mom was diagnosed with breast cancer on October 13, 1989, at age 35. Doctors at MD Anderson Cancer Center told her cancer she had was particularly aggressive and that she would not live beyond 5 years. It's the kind of diagnosis that would strike the deepest kind of fear in your heart, the kind that would make you want to give up. But my mom was not ready to give up. Not the kind of woman she was. She endured 6 months of chemo, radiation treatments, many surgeries, and all the while stayed optimistic. My mom met with other cancer patients, sharing her faith and her strength, her experiences battling cancer, and caring for our family. She felt fulfilled helping others, even when facing a terrifying situation herself. In year 3 of her battle with cancer, her doctor said she needed to stop treatment. It was just getting to be too much for her body. There was nothing more they could do. In 1993, however, my mom returned to the hospital. Her doctors told her there was a new clinical trial, a new drug derived from the bark of a Pacific yew tree that showed some promise. The San Antonio Cancer Research Center, the UT Medical Health Sciences, Dr. Peter Ravden was interviewing candidates for phase 1 trials of the drug called Taxotere. After initial interview, the doctors actually told my mom she didn't meet the protocols and denied her access to the program. But Dr. Ravden, amazed at her strength and that she was showing through cancer treatment at such a late stage, applied for an exemption for my mom from the National Cancer Institute, and she would soon be patient number 1 in the Taxol clinical trial. The initial results were incredible. Her tumors shrank at an accelerated rate. There were minimal side effects, but it wasn't enough. My mom, Susan Carroll Crenshaw, she died when I was 10 years old, and is the reason I care so much about healthcare innovation. My mom knew that this clinical trial would mean a small extension of her life at best. They didn't know how to apply the drug yet. She knew that while Taxotere would not ultimately save her life, her trial would provide doctors like Peter Ravden the scientific research they needed to improve the drug and save others. Taxotere would go on to become one of the most successful cancer treatments, saving the lives of countless women diagnosed with breast cancer, just like my mother. Because of people like Peter Ravden and his dedication to healthcare innovation, my family had hope, just as so many other families have now. And it is in the spirit of my mother that I'm proud to award the Susan Crenshaw Congressional Healthcare Innovation Award every year at this summit. We actually have a video I'd like to play that gives a little bit more background about what this award means.
I lost my mom to cancer when I was 10 years old. And before she died, she was actually patient number 1 for a brand new treatment called Taxotere. She didn't make it, all right, because she was part of that first contingent of patients. But that trial and that innovation and that investment, that led to countless other cancer drugs that a lot of people now survive because of. When I give an award to somebody, like I'm going to do, the award is called the Susan Carroll Crenshaw Award. And it's indicative of the fact that innovation saves lives. I want to recognize some people who've done some amazing things in healthcare, and we want to reward them, and we want to let others talk about what they're doing and tell the public, as we invite everybody, tell the public what they're doing.
I can think of no one more deserving of this award than someone who helped lead our country through the COVID-19 pandemic, former Commissioner of the Food and Drug Administration, Dr. Stephen Hahn. Dr. Hahn started at the FDA in December of 2019, which was a heck of a time to take that new job. Just a few short weeks, he would be in the forefront leading America's response to an unprecedented global pandemic. Because of Dr. Hahn, America was able to unleash the unprecedented power of healthcare innovation to win the battle against COVID-19. He's been an advocate for advancing medical innovation throughout his lifelong service in the healthcare space, and it is an honor to present him with this award in my mother's name. And it's my honor to welcome Dr. Hahn to the stage right now to accept the 2021 Susan Crenshaw Congressional Healthcare Innovation Award. Right there for you. Thank you, sir.
Well, good morning, everyone. Congressman Crenshaw, it's really an honor to be here today with you in Houston, formerly my hometown. Now consider Austin my hometown, but Texas is a great place to be from, and it's great to be here. And actually, it's great to be here with esteemed medical colleagues who are doing such tremendous work. And really, the topics, Congressman, that you picked in terms of innovation really speak to the issue of why we're here today. And congratulations to everyone here. It's also great to be at Rice University, my alma mater, and one of the, if not one of the best, if not the best, institutes of higher learning in the world. So it's great to be here. Thank you. I also want to shout out to Eric, my friend, Deputy Secretary Hargan, who I worked with during Operation Warp Speed. Really tremendous operational and financial support for this. Really great to see you here. It is quite an honor to receive this award. Congressman, what a tremendous legacy or way to honor your mother's legacy. As an oncologist by training, I know how courageous cancer patients are, and the participation in a cancer drug trial that went on to save so many lives is just indicative of what we're trying to talk about here today and what we need to maintain in this country. The importance of innovation and how innovation can improve human health. Now, it's an extraordinary time in both science and medicine. Every day we are witnessing unprecedented progress against human disease. I will argue that it is because of our investments in science and our robust private sector that we are where we are as a country. Investments in science and medicine are generating new treatments for life-threatening diseases, cancer, diabetes, heart disease, and injuries like traumatic head injuries. Science and hope, they go hand in hand. Being a cancer doctor, I know that very well. Science leads to innovation, which leads to hope. We can be optimistic about our future and our children's futures when we embrace and support innovation and sustain an environment that allows science and the private sector to flourish. I had the privilege of serving this great country as the 24th Commissioner of Food and Drugs. Now, the FDA is an agency of more than 17,000 individuals who are dedicated to serving our country. FDA regulates about 20% of America's GDP spending every year: tobacco, food, medical products, drugs, devices. That's a staggering responsibility, ensuring the safety and efficacy of drugs, medical devices, and the food supply in support of America's well-being every day. They are true American heroes, and I can assure you that they embrace every day this responsibility and do an outstanding job on behalf of the American people. And there is no critical substitute. There is no substitute for this critical oversight that ensures that when you go to the grocery store, the pharmacy, or even when you go to the pet store to buy dog food, that you and your family can rest assured knowing the products are safe and effective. This high bar of product safety and efficacy set by the FDA is the gold standard around the world, and it provides the American public with assurance that their health is prioritized and protected. Now, as Congressman said, when I first started at the FDA, it was December of 2019, I thought tobacco and e-cigarettes were going to be the big topic to tackle at the FDA. And just like most predictions in life, that was totally wrong. But I established 3 priorities in my first month for the agency during my tenure. And they're tenets that I carried throughout my career and intend to continue to carry throughout my career. And I'd like to share them with you today. The first was to spur and enable innovation. And really what that means simply is getting new medical products into the hands of the American people and American American providers as safely and as quickly as possible. In other words, cutting unnecessary bureaucratic red tape, but doing so without compromising the safety and efficacy of those products. Now, when I was at MD Anderson, we used to say cancer never sleeps. We have to work really hard for our patients, and I see people here in front of me who do that every day. And that was true during COVID-19. COVID-19 and the pandemic wasn't sleeping. We had to do our job to make sure that we cut all unnecessary bureaucratic red tape, but make sure that we did our job of safety and efficacy. The second priority was to unleash the power of data to make better decisions regarding the safety and efficacy of medical products. And Congressman, your proposal for how to move forward in the healthcare system, I absolutely love. We can use data to help with that for sure. And then finally, the third priority was to incorporate the voices of the American consumer and the patient in every decision we made. Just like medicine, what FDA does cannot be done in a vacuum. This, I think, is part of the empowerment that the Congressman was talking about. What, of course, I didn't realize is that in 6 weeks after starting at FDA, COVID-19 would come, and that it would be more important than ever that the FDA and American people had innovative, data-driven solutions to the problem that face us. We hope that a year like 2020 is a once-in-a-lifetime event. We remember and honor those who died from COVID-19, as well as the heroes in our healthcare system, and heroes in research and development who really worked tirelessly, as Congressman Crenshaw said, on behalf of our country and its citizens. I'd like to take a moment to talk about the past year, not because that this should be about COVID-19, but because I think what we did last year as a nation in response to COVID-19 highlights the importance of innovation and how that contributes to human health. And I have great faith in this great country that this past year will serve as a resource for the future and that our country will emerge stronger and more prepared for that future. For the FDA, the pandemic meant a doubling of our workload overnight, with the need to continue all of our regular responsibilities of approving cancer drugs, diabetes drugs, heart drugs, while also prioritizing and expediting medical products to combat the COVID-19 pandemic. What it did not mean was compromising the safety or efficacy of any product in any way. This can be done. We showed that it could be done last year, and it can be done moving forward. Two examples stand out to me from last year. The first is COVID-19 tests. Now, there was a lot written in the press, et cetera, about testing and how long it took, but I want to point out a few things. It takes months, years to normally develop diagnostic tests. Remember, the virus was first identified at the end of January and published. Now, it takes some time to develop those tests, but in a very short period of time, this country, our great private sector, in partnership with academia, developed COVID-19 tests. And I can tell you that the FDA reviewed those applications, and within a few days, not business days, a few days after receiving those data, we approved or authorized the tests that came before us, which is a remarkable turnaround time, certainly from the private sector and academia, but also from the regulatory body. And this meant that within a few short months, COVID-19 tests were available locally to the American public. The second is COVID-19 vaccines, and we all know that story. From identification and publication of the gene sequence of the SARS-CoV-2 virus in January to the ultimate authorization in December of 2 vaccines. We're talking about 11 months. Now, the fastest time a vaccine had been developed previously was approximately 4 years. We're talking 11 months. Now, that, my friends, is astounding. We have to thank the scientists in the private sector who found these safe and reliable means to help protect us. But that's healthcare innovation at its finest, and in my opinion, quite honestly, it's miraculous. Today, as we carefully navigate our way out of the pandemic, we have an ever increasing evidence that the COVID-19 vaccines are the best weapons we have against this enemy, and we can see light at the end of the tunnel. None of this could have been accomplished without science and the American and global private sectors, along with a flexible regulatory approach that maintained the FDA gold standard for safety and efficacy. Now, I want to take a moment to thank Congressman Crenshaw and his colleagues in Congress, often derided in Congress, politicians, et cetera, but I have to tell you, Congressman, your support of the CARES Act and Operation Warp Speed, I believe, will go down in history as one of the most consequential and wise investments of taxpayer money that we've ever seen. Thank you. And very importantly, we should also thank the tens of thousands of Americans who participated in clinical trials, just like Congressman Crenshaw's mother, which generated the data that allowed the FDA to safely authorize those medical tools. So when you leave here and you talk about science and data and medicine and hope, let's talk about the clinical trials we have to perform. Let's talk about participation in them. Let's talk about how we generate the data to actually make these advances. So the question that I have now is, as we stand here today, what next? So what do I believe are the most important lessons from the COVID-19 pandemic, and how can we apply those lessons in the future? The first is the critical value of a robust and vibrant private sector in healthcare that deploys its resources to perform research and generate data in support of the development of innovative medicines and other products. And of course, the value of our investments in basic science at great institutions like Rice University. I believe we would not be standing here today, right now, face to face, 3 dimensions, as I think someone said. Many of us protected against COVID-19 through vaccination in the absence of a strong private sector, of course, aided by basic research. Given what was accomplished in response to the COVID-19 pandemic, is there any reason why we can't continue to foster other critical medical innovations in a similar way? And I say no. Hope and science. I believe that by creating and sustaining an environment that supports science in the private sector, we can see more innovation and even faster development cycles. Think about that, faster than 11 months for a vaccine. Pretty remarkable. There's no reason we can't get there. I also believe that the FDA can continue to play the important role of providing vigorous oversight while fostering private sector innovation. We can have both. Most importantly, and this is very important, as a former public health official and involved in public health policy, there should be an extremely high bar for any government intervention that stifles innovation. A second major observation is that in the COVID-19 pandemic, the most vulnerable among us were the most impacted socially, economically, and medically by the pandemic. This is a stark reminder of the disparities that exist in terms of access to medical care, access to innovative medical products, and in levels of trust of the healthcare system. It is tragic that those among us who are the most likely to benefit from the innovation in life sciences are also the most hesitant to trust these innovations and have the least access to them. It is a moral imperative that we reduce and eliminate these disparities. And finally, we must rebuild trust in medicine and science that has been eroded in a number of ways over many years. I believe that the private sector once again can help us with these problems as we think about ways to reduce and eliminate disparities. We should create incentives for the private sector to develop products that are made available to all of us. We could, for example, create a regulatory framework that provides incentives to companies who develop ways to reduce disparities to innovative medicine, vaccines, and devices. And we need to re-examine our delivery systems with an emphasis on improving access. After my service at the FDA, I joined Flagship Pioneering. Now, many of you don't know Flagship Pioneering. It really is an incredible company that call ourselves an innovation company whose core principle is the use of science and data to develop innovative medical products to transform healthcare and sustainability. I'm really enthusiastic about working on an initiative called Preemptive Medicine and Health Security. Now, this is developing ways to create a shield against future threats to our health, as well as addressing the burden of chronic health conditions. And once again, combining science and the private sector to innovate and improve human health. I believe that efforts such as these can have a profound effect on our country and on our health, and for the ability of Americans to enjoy every moment of every day in this amazing country, unhindered by chronic health conditions or fear of another global pandemic. So in closing, it is an honor to stand before you today and accept the Susan Carroll Crenshaw Congressional Healthcare Innovation Award. I accept this award on behalf of all of my former colleagues at FDA, my new colleagues at Flagship Pioneering, others in the private sector, the frontline healthcare workers who did so much during this pandemic and always in our country, and each individual who suffered or lost their life because of COVID-19. I ask all of us to work together as one nation under our shared goal of further enabling healthcare innovation that can transform our lives. Science and hope. Science and hope. Congressmen and guests, my sincerest thank you.
Okay, excellent. So we're going to run this kind of like a TED Talk. That's the format of today. Obviously, the chairs are over here. We're going to be sitting with our guests, so you guys won't be able to see as well. There's plenty of seats. We had like 350 signups for this thing, but you guys are the ones who showed up, so thank you. All right? But yeah, so I don't know if you'll be able to see. It's up to you. Plenty of seats over here. I'm going to read our first introduction. These are all very impressive guests. So again, thank you to our guests for being here. This is going to be really great. So the first one is Dr. Lisa Forbes-Satter at Texas Children's Hospital, and she has created a way to reverse type 1 diabetes through precision medicine. Advances in healthcare should be moving our system towards personalized, modern, agile medicine and delivery, and these are the innovations that are driving down costs and changing lives for patients. One such innovation is this, and it's being introduced by Lisa Forbes-Satter, and we're going to hear from her right now and her patient, Travis. Thank you. Give her a round of applause, please. You gotta help me out here. He's on? Yep.
Yeah, they sound like they are.
Dr. Forbes, thank you so much for being with us today. This is a huge accomplishment, so I'm just going to ask you some very simple questions. For those in the audience who are maybe not as familiar with type 1 diabetes, Can you help us understand this form of diabetes and the challenges in actually treating it?
Sure. Thank you so much for having me today. I think that your speech, the video, and Dr. Hahn's speech set up this talk so nicely. Just as a personal note, I am a breast cancer survivor that benefited from Taxicare treatment and precision diagnostics in medicine. So I can sit here today with that kind of history and then motivate towards finding those kinds of things for my own patients. So thank you so much to your family, because I'm here today to help other families because of you, and I think we need to pay that forward. Science and hope, perfectly set up. So type 1 diabetes is actually driven by a hole in the immune system. So the immune system gets a signal and the switch doesn't turn on properly. In fact, it turns on a bad light, so to speak. And so then the immune system thinks that the pancreas is a foreign object and starts attacking it. So why does one particular person's immune system start attacking the pancreas is not quite clear. And so for the patients that have type 1 diabetes alone, what drove their particular story to develop type 1 diabetes is a big question. So what I do as an immunologist, because I'm not an endocrinologist, I don't specialize in hormones and the pancreas, but I specialize in underlying genetic mechanisms of the immune system. And I take rare immunologic disease and I learn why the immune system is wrong, so I can appreciate how it's supposed to be right. So in patients like Travis, who has a rare immunologic disorder that drives autoimmunity, I can pinpoint what the problem is and try and fix it.
So did you set out actually trying to fix type 1 diabetes? Because you're an immunologist. So how did this treatment come about?
Right. So, like Dr. Hahn, he thought he was going to be doing one thing with his career, and then all of a sudden life changed. So reversing Travis's type 1 diabetes was actually an unexpected result of using precision medicine to treat his underlying immune disorder. So we kind of borrowed a cancer drug because we, from very innovative scientists before us, learned what the actual mechanism of his underlying immune problem was. It's called STAT1 gain of function, and it's a rare disease. I think there's about 600 people in the world that have been discovered with it thus far. So, but
Congratulations.
Oh,
Thank you.
yeah, right? I know, he's unique in many ways. And so, but underlying, when STAT works so hard and overworks, it drives this bad signal to happen, this bad light that's turned on. And so we borrowed a cancer drug that works in the same pathway as STAT1 does to calm it down and to balance it. And all of his autoimmune manifestations reversed. It was just remarkable because no one had ever published or reported that you could reverse type 1 diabetes. The paradigm in the medical community is that once it occurs, that's it for life. You're insulin dependent for life. So we were quite pleased, and I have to tell you, Travis is actually the one that realized his diabetes was reversed. He was about to start college, and I'm gonna call you out here, Travis, okay? You can supplement the story if you want. He was, he said to me his last visit before he started his freshman year of college, Dr. Forbes, I don't think I need my insulin anymore. And I said, oh, no. You might not need as much. We might be calming things down, but do me this favor. You're starting your freshman year. I don't want to know what happens at college, earmuffs, but don't change anything because I don't want you to end up in an ER in a city that I don't know. And so he said, okay. He looked me square in the eye. He said, no problem. And what did he do?
Why did you think that, though? What was going on that you thought that you didn't need it? Curious.
When I would take insulin, I would just get like super low blood sugars, and I am pretty active, so like I just honestly sometimes I just wouldn't take it and I would still get low blood sugars, and I was like, yeah, this sucks, I don't want to take it. So
Pretty simple explanation. Yeah, I was wondering if there was.
So that's what he did. He got to college, and for 4 months he didn't take it. So when I saw him again,
Became a rebel.
well, or the definition of a freshman in college, right?
I promise I'm a good patient. I promise.
He takes his immune suppression on time, I promise. So I just did his blood work, and he was right. He didn't have evidence of type 1 diabetes.
So what's the science behind this, and as best you can approach layman's terms?
Okay. Well, I have a cartoon if we want to put it up.
Cartoons are good for layman's.
Yeah, it's a. What I have done is made, and actually my one of my staff, Dr. Vargas Hernandez, actually made this cartoon, so I have to give him credit. But what I did is I took the round cell and I kind of opened it up and made it in 2-dimension. So briefly, when if you go to the third slide. Okay. So if you'll see over here in the corner, that purple little bird-like thing, we're going to call that the immune stimulus. So when the immune system sends out a signal and stimulates something, it gets to a receptor and it activates an immune pathway. Okay, so this one's called the JAK-STAT immune pathway. STAT1 is essential in the immune system and many other tissues to turn on and off all of our immune responses. To COVID-19, it is important in viral defense. And so one of the sister drugs to what Travis takes is actually one of the drugs that Dr. Hahn's FDA committees approved for the anti-inflammatory of SARS-CoV-2 infections. So what happens is JAK molecules activate, turn on STATs, they go to the nucleus, and they drive whatever the immune response is. Ruxolitinib, which is the small molecule JAK inhibitor that we borrowed from the cancer space, blocks the JAK activation, so STAT can't really be turned on. So what happens in Travis's disease is that the STAT1 gets turned on too much, so it drives that overactive immune response causing the autoimmune disease. And so what we did is we calmed down the inflammation. We balanced out his STAT1 activation so it could do what it needed to do normally, but not turn on those bad lights. And it calmed down the inflammation and the immune response to the pancreas, and it allowed the pancreas to wake up again.
That's fascinating. So I guess the million-dollar question then is, can it be applied more broadly? Can it be scaled? Cost? What's next for this?
So it really is an expensive drug, and so I think it can be, with the right data and the right science, be applied more broadly. There's one clinical trial in the world with ruxolitinib's sister drug called baricitinib. It's for patients in Australia with new onset type 1 diabetes over the age of 18, and it's run by the JDRF in Australia. That's the only clinical trial available in the world right now for this class of drugs. But because of our work here and my collaboration with some very smart endocrinologists across the country, we are now crafting the pilot studies that we need to gather the data on patients with STAT1 and another STAT gain-of-function disorder, so we can understand, again, these rare diseases teach us so much. We learn what is wrong with the immune system so we can understand how it's supposed to be right and modulate it with drugs that have been created to target the particular immune pathway. I mean, a great example years ago of how this happened was the bubble boy. He had no immune system. He lived in a bubble. He was treated at Texas Children's. NASA made his bubble for TCH and for his home. And so we used the innovation here in Texas, to drive that. But what my mentor and the honoree of our Center for Human Immunobiology, William T. Shearer, did is he learned from David. He learned the underlying reason that David's immune system was wrong. And his innovations and the science that he gathered is driving precision medicine in cancer, in autoimmune disease, and all of those kinds of things. So the precision medicine that are moving forward, awareness of immune disorders like Travis is going to give us the opportunity to treat better our autoimmune diseases, identify biomarkers so we can screen patients before they develop the diseases, hence the importance of expanding a primary care network and innovating to give them the tools that they need to further treat our patients, and then apply precision, personalized, patient-centered medicine to each and every one of these patients that come to us with these disorders.
So that leads to the question, sounds like it's difficult. You said there's only one clinical trial in the world. What regulatory barriers do we have that are preventing us from moving forward with this and scaling it out?
So I see two main barriers. I see the, something Dr. Hahn spoke to is the regulatory barriers to bring innovation to the marketplace and to the patients and to the cost. So the first is the barriers. When we identify these mechanisms in rare disease and want to start looking at how to treat them, we don't have enough patients to power a clinical trial. And so we fail at the beginning in our preliminary meetings because it takes a lot of time to get the number of patients, settle on a number that the FDA will then allow us to go forth and gather the data. So the NIH actually just came out last year with an innovative idea of a basket clinical trial where you treat multiple rare diseases in the same space with one drug. And then that way you can power the number of patients. So thankfully, I think that we're going to be able to do that with the disorders like Travis in the coming years. And that will help us in terms of give rare disease another mechanism towards breaking down those regulatory barriers. The last thing is the cost. A drug like ruxolitinib can cost $10,000 to $25,000 a month. Insurance copays are astronomical. So when Travis started the drug, his insurance company charged him $25 a month. And then after 2 years, decided that it was too expensive for them and changed his copay to $2,500 a month. Well, that's vastly lower than $10,000 a month, but still, like, majority of our patients, your constituents, cannot afford a drug that's $2,500 a month. And so what I did is I went to the company and I said, and I applied for compassionate use. And so they gave me the new version of ruxolitinib on an individual investigational drug trial for compassionate use. And so for the last 2 years, Travis has been doing just as well on this new drug, and it's free for him, but that is an arduous task for every single person who needs an expensive drug to have their physician have to institute a compassionate use trial. So we have to be better at understanding how we can do this together and innovate from a policy, regulatory, and a science perspective, and bring all of those things together to the same table, because for us, that's what makes it work. And, hopefully we'll be able to prove to the rest of the scientific world that these basket clinical trials do work so we can move forward the rare disease space. But again, it's rare disease that teaches us how things go wrong, so then we can treat the underlying mechanisms for type 1 diabetes. And I really do believe that in the next few years, given the pace at which recognition is coming, especially through invitations like this, that my colleagues and I are going to be able to identify some biomarkers that will make it helpful and give the incentive for a broader clinical trial for new onset type 1 diabetes. I get calls and emails from parents all over the country and all over the world that have read our article, and I have nothing to offer them. And so hopefully by trying to break down some of these barriers, partnering with our representatives and our private sector and our regulatory agencies, we can break down these barriers and maybe have an answer for them in the next coming years.
Well, thank you. Last word, Travis. How do you feel?
I feel great.
Great. Man, a few words. Okay.
Thank you, guys. Thank you so much.
All right. Next, please welcome to the stage from Spark Biomedical, Daniel Powell. Give him a round of applause. All right. Come on up. So Spark Biomedical is a Texas-based medical device company and developer of an FDA-approved wearable neurostimulation solution for opioid withdrawal. And Spark is dedicated to further studying and developing solutions for long-term addiction recovery. Just last week, CDC released the opioid overdose death numbers for 2020, and they're not good. The death rate increased a staggering 30% to a total of 93,000 Americans. 93,000 lives lost to opioid overdoses. And to put that in perspective, that's 250 lives lost each day. So thank you, Dr. Powell, for being here and for your innovation. So
Thank you.
let's start right from the beginning here. 4 out of 5 people on illicit drugs started with prescription pain medications. So in your experience, how does a person go from a prescription pain med for a surgery to a drug addiction?
Yeah, so what we know is opioids are a very addictive, diabolical drug and also miraculous in their ability to heal or ability to relieve pain. When misprescribed and used chronically, they have 2 simultaneous effects. They drive a deep physical dependence, meaning you're going to go into withdrawal if you try to stop taking it, and they're going to drive tolerance, which means you need to take more and more to not go into withdrawal. So you get 2 decades of this, and you get 4 out of 5 people that are on heroin today started on pain medication. So somewhere along the way, your doctor cuts you off, or you lose your job and you lose insurance, and you start to go into painful withdrawal. You have no choice but to start to try to find how to alleviate that withdrawal. And withdrawal just overrides common thinking. It overrides your logic. It's fight or flight. And so people are really at instinctual need to make it stop versus the logic of, I got to get through this very painful process.
And so your device changes that and intervening early on in an opioid withdrawal process. So how does it do that? How does it disrupt this process, and why is it so different from other treatments?
Yeah, so the body runs on 2 basic substances. It runs on chemicals and electricity. And so all pharmaceuticals are going to be a chemical-based solution, where we are an electrical nervous system-based solution. And so what we've known, and we build our science on researchers going back 50, 60 years or more, is that you can stimulate the nervous system to create physiological changes. And what this has been being explored for years and years. We traced some original auricular ear stimulation back to Russia in 1947 with this big device that we are glad we don't have to use today. And even 10 years ago, I was working in deep brain stimulation for Parkinson's. So you put a wire in somebody's brain, stimulate a very specific part of the brain, and their tremor will stop. We're thankful that we've been able to take this out of the brain, not drill a hole in the head, not have a very expensive surgery, not introduce also more pharmaceuticals with side effects, but access the nervous system this way.
So again, going to the science, but in layman's terms, how exactly does that work? Why does it work?
Yeah, I know, because it sounds like too good to be true. We stimulate 2 different cranial nerve branches. So on your ear, I'll turn this little divot here is where the trigeminal nerve comes up, and inside the ear in that ridge is where the auricular branch of the vagus nerve comes up. And when you stimulate both these nerves at specific frequencies, you drive 2 important physiological changes. One of those changes is you bring down fight or flight. So you take the autonomic system and you do what's called decreased sympathetic tone. That's that desire to run. It's your caveman brain that tells you run from saber-toothed tigers just instinctually and bring back the calm. And so that takes away the anxiety. But really, more importantly, anybody in withdrawal will tell you that's been addicted to drugs or just physical dependence, they literally believe they're going to die. And that's that instinct. And so we calm that down, remove that portion of that amygdala, the lizard brain that's firing and telling you that. And then the other thing we do is when you're stimulating these nerves, you drive endogenous endorphin production. So if anybody's ever seen a football player like Randy Grimes here, they get hurt on the field and have a broken finger, and they're like, it doesn't even hurt. That's your endogenous endorphins kicking in, that's overriding the pain signal. and filling the natural opioid receptors in your body. So by filling the opioid receptors, reducing the cravings, reducing the anxiety, we can bring somebody out of withdrawal.
Is there like a picture of, like, what does it look like?
Oh, I forgot to click. Here's the device, and little ear-worn device, little belt-worn clip. And actually, we have a video. So this sounds miraculous. We have a video clip of a brave young lady that was in our clinical trial and said she wanted to do a testimonial. So if we could run that real quick.
How long does it, while we're waiting for that, how long does it take to work? I mean, what does the patient feel?
Yeah, so great question. So we are able to take somebody in full opioid withdrawal, that this looks like on the floor in the fetal position, running to the bathroom every 15 minutes, gastric distress, sweating. 1 hour of stimulation brought 93% of the patients into mild or no withdrawal. And then they wore it through 5 to 6 day detox process, which is the typical time it would take to get through the worst of withdrawal out of your system.
And have you been able to study recidivism on this?
That's our next study.
Okay.
So that's our next study, and we'll talk about. I'll talk about it here in a
Okay.
sec. We'll
We'll get to the
watch
video.
Eliza.
I've been through detoxes before. I've been on the taper and I've experienced the pain that it still like causes, and I experienced this, and it's completely different because you don't have to worry about waking up in the morning and waiting for your taper and getting sick and like all this stuff. Like it's already making you feel better. Like it's already helping you like physically and mentally was one of the things that I noticed, because I didn't feel foggy from all the taper meds. Like I just felt clear. And like talking to the other people around here, I'm like, they don't feel like as clear as quickly as I felt clear, which was really interesting to me. When I first came in here, oh my gosh, I was so angry and I wanted to leave. I wanted to go home. I wanted to get high. I remember I told everyone, I said, if I'm not getting meds, I'm leaving and I'm getting high. And I don't care what you have to say about it, like I'm going. I don't care. I don't want to be here. And then after like 2 or 3 days, because I was feeling like so myself again, I don't know, it's so hard to explain, because I literally, when I'm getting high, like I've become a completely different person. So, the fact that it worked so quickly and I didn't have to like worry about taking like more drugs to like fix the drugs, sorry. I finally like feel like myself again, and now I'm like going on to do more treatment, which was not the plan originally. The plan originally was just to come here, detox, and like after like a couple days of like doing this and just like talking to people and being myself again, like I've made like a huge decision to like continue my treatment onto another place, which is like my parents are just so like grateful for, and I'm really grateful for. So
That's a pretty strong testimonial. 2 to 3 days. I mean, it just changes your life in 2 to 3 days. How much does this thing cost?
So we're in the early phases of launching. It's about $1,500 to $2,000 for the therapy.
And how much is it costing these days to try and treat someone with traditional means?
Yeah, well, it's $1,000 to $2,000 a day just for the inpatient, facilities.
Yeah.
The meds are kind of older, so they're on generics so they're not outrageous.
There's care, and it's a rehab facility.
Yeah,
it's all these things.
And so, typically the process is 7 days in acute detox, and then 21 days in outpatient or some kind of facility. But to really beat addiction, the typical talking point is, get through 90 days. If you can make it past the 90-day mark, the statistics go way up. 50% of patients relapse the first month, though, post-detox.
Well, I'm really excited to see what the study on recidivism is then. And I mean, it sounds, just from that testimonial, I bet it's promising. Okay, so why can't insurance companies pay for it?
Oof. So you would think the fact that we did all the testing, the clinical trials, the R&D, that all the proof we've done, and the FDA accepted it, and I think this might have been accepted under Dr. Hahn's watch, so thank you. You would think then we're there, and but the part of the government, the FDA, that handles approving the safe and effective device, and the part of the government that handles reimbursement, CMS, the Center for Medicare and Medicaid Services, which we use one M for two M's, which kind of already shows you you're in an uphill battle how they named it. They have an arduous process. And so the first step is a company like us goes to them and says, hey, will you cover this? And they look in their big book of things they cover, and they go, neuromodulation for opioid withdrawal. Nope, doesn't fit. The worst thing that could happen to us is they go, no, but that looks like a TENS device because TENS device stimulate the skin. We'll reimburse this at $100, and then Spark's out of business. And you can't undoing a bad decision is worse than waiting and getting it right. So that's step one. So then you got to go to Congress and go to your local congressman and say, hey, can you help us say this should be something that's covered? And so then now it's covered. Well, then you have to get a code. And so you go and get a unique code and go through the process. And all the private insurance carriers inherit CMS's codes. So if I go to Blue Cross and Blue Shield and say, hey, will you cover this? They'll go, do you have a code? And I say, not yet. And then they go, well, we'll throw you in a miscellaneous bucket. So every single patient requires a medical letter of necessity. And it can be done, but it's not fast.
Why did private insurance companies do that? You think is it a liability issue?
I think it's organization and consistency. If the Blues and United and everybody had all their own codes, it'd just
be a mess. That's true. And so they rely on CMS, but CMS is a government bureaucracy.
Yep.
And then they put the owners the burden on Congress, but it's not clear to me that that's even what is needed, and that it couldn't be solved at CMS with a little bit of forward thinking and innovation and desire.
Yeah, and if you want to change CMS, being a startup isn't the one to do it. You know, the really big Johnson & Johnson, like they could have some influence maybe on CMS. For us, it's, you know, you're dealt the cards and you just got to play the game.
So what else are you working on besides this, really what's an unbelievable treatment?
So we have two projects. You mentioned what I'll call relapse prevention, so long-term recovery. So instead of wearing our device for 7 days, wear it for 90 days, not 24/7, but less and less, and manage cravings. We saw reduction in depression scores, reduction in PTSD scores, which is trauma, which is at the core of all addiction most of the time, and studying that and really taking this to an addiction recovery product versus a withdrawal relief product. Our other major initiative is with neonatals. So there's 38,000 babies born dependent on opioids every year. It's horrible to watch. They scream and cry, and they're in the NICU for 24 plus days. These are babies that are on the state's dollar all day long because their parents don't typically have Blue Cross Blue Shield. And so we completed a pilot study of 8 babies, had incredible results. We're able to get them out of the NICU, or at least off of oral morphine 14 days faster instead of 24 days, more like 10 days. So really good results. And both those studies are funded through the NIH, and so really appreciate, when we talk about parts of the government not working, parts that are really good is there's something called the HEAL Initiative through the National Institute of Drug Abuse, and they have been really helped us move the science forward and fund us. So that's been, you know, for a small company, just invaluable. And
that brings me to being a small company, being a small startup in a place like Houston. How does the Houston and the Texas Medical Center, how does this ecosystem help a startup?
Yeah, it is a very rich ecosystem. So like I said, we have Rice, Texas Medical Center. Texas Medical Center has multiple incubators and accelerators that we've participated in or joined that community. My alma mater, Texas A&M, is building a massive new facility here for innovation in medical. But amazingly, we have all of our R&D is being done right here in engineering work through a company called Valentium, and they manufacture part of the product. So you can manufacture in America. This is possible.
It's a good news clip. Right?
Yeah. So another company, Galen Data, that's right here, handles all of our cloud-based solutions, cybersecurity, HIPAA-compliant data transactions, FDA-compliant. And then Positive Recovery Centers is actually a large evidence-based chain of recovery centers that will be rolling this out in the Metroplex as one of our first places here. So it's been really good for us, and it's been a very positive experience.
So we got a couple minutes. So actually, one last question. I mean, is there any hope on the regulatory front? Seems like, you know, we laid out the problems with CMS. Where are those conversations now?
So we're hiring lobbyists, and we're hiring. When I started this, I never, with my two partners, we didn't have our eyesight on that. We were focused on science and R&D, and it's kind of like, well,
And now it's a whole new world. But this is urgent. I mean, it's an urgent. Seems like an urgent need that works, and there's no reason to think. I mean, FDA already proved it, so it seems safe. I mean, you would think this is a no-brainer.
You would, and I want to compliment to you. Mental health is always the last to be thought of. Carlos Torrado, who was the physician that ran our clinical trial, said psychiatrists are the redheaded stepchildren of doctors, and addiction specialists are the redheaded stepchildren of psychologists or psychiatrists. So mental health's largely looked over a lot, and you actually have 50% of the presenters here that are covering this. So that's unusual, and that's fantastic. But yeah, it's looked over.
Because I need a lot of mental health. Okay. Thank you so much, Doctor. Appreciate it. Excellent. All right. So next, if I can work my own binder here. From Hamilton Health Box, Dr. Glenn Davis, thank you so much for being here. I talked about direct primary care earlier. Yeah, give him a round of applause, please. So Dr. Davis is on the forefront of direct primary care as Chief Medical Officer of Hamilton Health Box. They've been able to provide low-cost, high-quality health care directly to the patient, cutting out the middleman. You know, it's like paying a monthly gym membership. So we're going to hear what that's all about. Glenn, thank you so much for being here.
Thanks for having me, Dan, and great lineup of speakers. It's fun to be here. Thanks.
Yeah, well, it says the speaker. You know, but I agree.
Before me, the lineup
I agree.
of speakers before
I
me.
agree. Glenn and I are friends, so thank you. Thank you so much for being here. Dr. Davis, please, because give us an overview. I briefly touched on it in my remarks. Give us a little bit more detail on the direct primary care model. Why is this a game changer? Why is this the future?
So direct primary care, there's two distinguishing characteristics. One is the patient pays a monthly subscription fee, and that basically covers all primary care services. Secondly, there is no third-party billing, so the physician never sends a bill to the insurance company for reimbursement. The reason it's a game changer is because it creates the easily affordable, convenient access to your primary care physician. And that's something that any American would want, and we can deliver it to any socioeconomic status. That's why it would be a game changer.
Describe the model, though. So, I mean, like I said, it's kind of like a gym membership, but
Right.
I mean, it really, I guess it's not that much more complicated than that. That's what's
It isn't.
so
It isn't.
beautiful
So
about it.
they pay a monthly subscription fee, and that creates this easy way to communicate with your doctor, whether it's via text or video or any type of email with your physician. It creates that relationship with the primary care doctor that's longitudinal instead of just a visit every 3 to 4 months and what happened between the visits. It's this direct, constant communication with your primary care physician, and that's what that monthly subscription fee allows you to do.
Well, and what's the average, you think, on these subscription fees?
It's usually about $50 to $75 a month.
That's pretty cheap. People pay more for their cell phone bill. But for whatever reason, people are just not willing to pay for healthcare. So trying to expand this is what I talked about. What's included in that generally?
So usually it's a basic comprehensive physical. So think an annual physical. Usually basic laboratories for screening are included in that. And then care and management of acute illnesses, upper respiratory infections, walking pneumonia, sprains, strains. And that's where a lot of the value comes from is, you don't have to go to the urgent care or the emergency room. You can text your doctor. You can get refills. You don't have to make an extra visit for that to happen. So that comprehensive annual physical, and then that constant communication for the day-to-day things that happen. People get sick. People have sprains.
Questions. I mean,
questions.
Yeah. I mean,
where do I go for referrals is another big one. Like,
Yeah.
who should I see for this if that's something you can't handle? So all that administrative burden that was never reimbursed before by an insurance company, it's part of the subscription fee. So the physician can request records, communicate with specialists, arrange follow-up. So that's the other added value there.
One reason I think Congress should pass this is because members of Congress get access to this exact model. They
Right.
don't call it direct primary care, but that's what the house physician is. We pay I think about that price actually, I think per year. And it's exactly that, right? It's not insurance, but you just get to see the doctor, ask them questions, they can assist you with primary care things.
And what that leads to is earlier diagnosis of illness. So you can treat a high cholesterol instead of a blocked artery.
Mm-hmm.
So you treat pre-diabetes before it's diabetes and leads to blindness and kidney failure. So that's what that relationship builds. It prevents further cost down the line because you're able to diagnose things earlier and address lifestyle concerns. And these are all things that it's not just another pill. It's addressing the whole patient, talking about their sleep and their activities during the day, their diet, and all those things. 70% of our health is, what we eat and what we do. And so direct primary care physicians, uniquely suited to fill that role.
And it's not just with individuals. You also contract directly with companies to provide
Yes.
care to all their employees. So you did this with Martin's Preferred Foods
Yes.
here in Houston. So,
Right.
so tell us about the success of that.
Well, I'll start with the success, and then I'll tell you how we did it. So the first year that we were there, we saved the employer over $500,000 in healthcare spend. We saved the patients over $60,000 in copays and deductibles. And so the way we were able to accomplish that is we put a fully functional microclinic on site that we used a lot of virtual technology to leverage that, bring the cost down. We put a full-time medical assistant on site. So she's there 8 to 5 during business hours. And then a physician and a physician assistant were available 24/7 for after-hour calls and weekend calls. And what we saw was a 30% rise in primary care visits, a 40% decrease in emergency room and urgent care visits. And so and then we were able to, treat chronic diseases earlier. We were able to diagnose conditions earlier, and that's the kind of success that we've had there. So.
Did it change because again, it's not insurance, but did
Right.
it change insurance premiums
Yes.
for the company?
Insurance premiums go down. As soon as you put a clinic on site, insurance premiums for the company goes down because everybody understands if you remove the barrier of access and put a trusted healthcare provider that the patient can go see, it will only improve care.
And is that encompassed in that $500,000 savings? That premium is that from premiums or is that just separate?
That's just separate. That's
Oh,
just
really?
cost and
So it's actually more than probably.
yeah, it's probably more than that.
Okay.
Yeah.
Wow.
Yeah.
Yeah. So it's and patients actually feel like they have a doctor.
Yes.
Because I mean I think a lot of people are not even sure, especially if they don't go to the doctor very often. Like, how do I even go about that process?
Right.
Do I have to call my insurance company or just find how does this work? It's annoying.
I
Or
think-
and then they just end up in an emergency room sometimes.
Oh, that doesn't happen. We have we have the medical assistant, and they are truly the shepherd for the entire workforce, and they know us. They know my physician assistant. I actually physically go down there and see patients at the chicken factory. Yep.
So this is this latest iteration. I think we have a video on this or
Actually,
demonstration.
I was gonna.
Yeah.
I do a quick slide and shows you what it looks like on the
Okay.
other end, but then I'm gonna video in and show you.
Okay.
We're gonna look at some people's ears, and you can see our when we do a televisit, it's really a virtual visit. So let me go get set up over here. And this is just a review of what we talked about. Full-time on-site microclinic. It's a team. We use a lot of telemedicine to help us, and we take care of a lot of primary and urgent care issues. And this is what the console look on the other side. The technology, in some places we actually put a box, and actually it's soundproof. And then over here on the left, you see what our console looks like. And I'll show you what it's, and this is, we actually have a fully mobile clinic as well. It's a fully functional mobile clinic. And this is actually where we got the health box from, is we can actually pull a fully functional clinic in a box and put it in a rural area. And we can talk about that more, Dan, about how we can serve patients. And then these are just all the iterations of what we're about to see on the other side. And then it talks about where the savings come with in-network referrals, decreased ER visits, increased generic prescriptions rate. We institute a new program where it's free prescription drugs for all our patients. And that's really improved compliance, decreased ER visits, obviously decreased sick days. I'll see entire families on site. Parents will bring their children on their lunch hour with their child, and I'll see their 12-month-old and the patient. So less time off work for the patient, less time off to go to the pediatrician, so we can take care of whole families there, and obviously increased employee satisfaction. So that's that. I'm going to try to log on here real quick and have my PA, and we can show you our technology. So bear with me for a moment. And so we can log on. We can log on from anywhere in the United States, basically. It should come on here in a minute. And you can see these are all our clinics, and this is one of our worksite clinics, and you'll be able to see it's truly a micro clinic. It's just Teladoc recently bought our vendor for our electronic virtual equipment. Hey Danielle, I'm live. So Danielle, if you want to show them how you look in the ears, you want to show them how. So Danielle is our physician assistant, and Rosie's our medical assistant, and they're going to show you how our equipment works. So you can see the kind of, it's not just once we get the equipment and we show you, it's just not FaceTime. And so this is how I will do a virtual visit. And you can see her ear, that's a normal eardrum. Obviously, it's a lot better on the smaller screen, so we can do it like that. And then, we can look at the ears, and we can look at. You can show the dermatoscope if you guys want to show the dermatoscope, Rosie. The dermatoscope. So we can also look at, and we can listen to heart and lungs. Obviously, the audio is not there, but we can listen to heart and lungs as well. And I'll show you one more. Just our dermatoscope. You can see the resolution. On the, let's see here if that works. So we can look at the ears, nose, and throat and get a really good look. And we can also use the skin, and then obviously we have a stethoscope that we can use, and it's just like being there in person. So
it's fascinating. And so that allows you as the doctor to see, you can utilize PAs to do this. It's just a much more efficient.
Oh, I guess the sound is coming through.
Oh yeah.
So there's the heartbeat.
Is it normal? Is she okay?
Yes, it's normal. She will survive. So this is what we can hear. Obviously, it's better with headphones on, but yeah, that's her. Then take a deep breath, Danielle. Yeah. Oh, wow, that's amazingly good. Okay, thank you, guys. Thanks.
Thank you.
Thank you. All right. So that's how we.
That's incredible.
Yeah.
Yeah, I wasn't expecting that. That's unbelievably efficient.
Yes.
That's great. Why is it called Hamilton? What's the story behind the name? Your name's not Hamilton.
Oh, my friend who's the CEO and I'm the chief medical officer, when we founded the company, I just liked the way Hamilton sounded. That's his last name.
Oh, it's his last name? Okay.
Dobie Hamilton.
Yeah.
Great guy.
Yeah,
Great guy.
He was a founder.
Yes,
too.
he was a
Good.
founder. It was like Davis Hamilton. I like
things,
Hamilton better.
A lot of good things about that. So, okay, what's my next question here? Okay, well, actually, I mean, we've kind of been over this, but I want to dive into this question. Being a quarterback, and this, as we mentioned before, a primary care physician is a quarterback for your health, for referrals and things like that. But, in my sort of vision for healthcare, I do see this model as being the first step, and the second step is, okay, well, how do you fix it? Because it's not insurance. How do you fix insurance? I like this model because it's that first step. It gives you a quarterback to figure out insurance, because like even smart people who know a lot about healthcare can't figure out what insurance they should buy. It is a very difficult process. So maybe explain why it's so important to have a quarterback.
So the primary care physician is uniquely suited for preventing disease. So they are uniquely trained and in the position to diagnose and treat conditions not only at early stage, but also help their patient through preventive measures, mammograms, colonoscopies, blood work. So that's number one. They're uniquely suited for that. Number two, they're uniquely suited for treating acute illnesses like we talked about before, bronchitis, pneumonia, sprains and strains. And then the thing that I've discovered, I think the most essential part of being a primary care physician is if you've developed that relationship over a long period of time, you know your patient, you're able to diagnose their conditions better. It's just that simple. 70% of what we diagnose is by history alone. 70% of what a physician diagnoses is by talking to the patient. And the primary care physician is uniquely suited for that. And that increase in quality and performance it pays dividends down the road with less complications down the road.
And you kind of briefly mentioned this, getting access to vulnerable populations, rural communities. How does this help?
Yes, I mean, you can see we can put a box anywhere, basically. Our model has worked best in the blue-collar population. We have, hourly wage earners who have very good insurance, actually, but have never had a chance to use it because they would have to miss 3 to 4 hours of work. And now it's 30 minutes. They'll bring their child to come see me because they don't have to miss work, or if they do, it's on their lunch hour. And that's been one of the biggest game changers for us, and that's really the vulnerable population we serve best. And so we've proven our model at the food processing plant worked, and we've also had one of our other models, a blue-collar situation, where we actually take the mobile van out to the work site. They're working 7 to 5. They don't have a chance to go to the doctor. We will actually take our fully functional mobile unit, go out, do physicals, draw lab work, diagnose conditions early, treat it before it becomes a problem. And they get to know us. Sometimes we even bring them tacos for lunch, so they know we develop a very good relationship with them. And so that's where it can serve.
Is that for when you're contracting with a company,
Yes.
though? Because I mean, I think that it seems like to me that the next step would be, and you would think that insurance companies would have an incentive on the individual market to reduce premiums for individuals who can prove they have a subscription to a DPC.
Right. Yes, you are correct. And we've been, actually, there's a couple of statewide institutions that have contacted us to serve their rural population.
Really?
Yeah, so we've already gotten that kind of interest.
That's good.
Because
that seems like the obvious next step.
It is.
And,
it is.
So what's next for Hamilton Health Box? What are you guys working on?
More of the same. One of the other things we've done, we've actually put a clinic inside of office buildings. So we have one anchor tenant who pays for their employees, but then we can go to the smaller companies and offer them a deal for if they have 20 or 30 employees. Say, hey, just pay us $50 a month and we'll take care of that. We'll take care of your primary care needs. And also down to the individual, the really small companies in the office building, we have individuals who treat it like their regular DPC clinic. They pay us a $50 a month subscription. We do all their primary care needs, blood work. And the other thing we've been able to do is negotiate imaging prices. We can get, CAT scans and x-rays at a very reduced price.
All right, so last question. Barriers to this model. I mean, what are the barriers right now? Is it just a lack of knowledge about the model, regulatory barriers? What is it?
So one barrier on the physician side is physicians usually make less money if they do the DPC model, but their job satisfaction is much higher because they're doing what they were trained to do, take care of patients, prevent disease. The other barrier is sometimes patients there is some hesitation if they have to pay the extra to $50 to $75 because they think that I'm already paying a premium. Why do I have to pay extra, if you will? And that's why I like the idea of the HSA. It's a perfect spend for HSA account. Would be able to use that for a DPC.
Yeah, it seems like the obvious first step.
Right.
Dr. Glenn Davis, thank you so much for being with us. Excellent, doctor. One of my doctors. I appreciate it. All right. I think this is our last one. It is. So back to the mental health side of things. From the Multidisciplinary Association for Psychedelic Studies, Dr. Rick Doblin. Thank you so much for being with us. So one of his, somebody who's received such treatment, John here, actually cornered me in the elevator in my where we live in. We have an apartment in the Navy Yard when we were up in D.C. And this is fascinating because he's like, hey, you need to look into psychedelic research. I have this incredible story about it. And I was actually just coming from a friend's house. I was coming back home that night from a friend's house who was telling me about his Marine, blown up in Afghanistan about a year before I was blown up, terrible TBI issues for years, and said that that psychedelic treatments had changed his life. So it was just very strange that I was getting both of these testimonies within the span of 24 hours. So we're going to hear about that today. This is focused on MDMA, also known as ecstasy. So there's that's the connotation here, and we're going to talk about the stigmas associated with that. So 7% of the U.S. population will experience PTSD at some point in their life. As many as 13% of combat veterans have the condition. In 2018, the VA spent 17, yeah, it's not 1.7, it's 17 billion on disability payments for over 1 million veterans with PTSD. That gets to a whole other problem with how the VA codes things, but okay. But Dr. Doblin and his team are in FDA-regulated phase 3 trials studying how an unlikely source, MDMA, might be able to successfully treat it. So, Dr. Doblin, thanks for being here. So you're using this therapy. You recently released a study in Nature Medicine that showed your treatment is a breathtaking 67% success in curing PTSD. So how does that work?
Well, first let me say that I started this nonprofit organization 35 years ago, and we've received $115 million in donations, so it's all privately funded, and we have bipartisan support from Rebecca Mercer, from Elizabeth Koch, from the Rockefellers, the Pritzkers, the Buffetts, all the way to George Soros. So we have bipartisan support. We've been able to take this.
Keep that to yourself. All right.
But as far as how does it work, and we're committed to the nonprofit public benefit model. But how it works, the most important thing to realize is that it's therapy first, and the therapy is helped by the drug. But it's not just here's a pill, it'll make you better. So to show you what the therapy is. It's basically 42 hours of therapy over 3.5 months. And within that, you have 3 days of 8-hour sessions, and this is the design for our phase 3 study. So you either get MDMA with therapy, or you get therapy with an inactive placebo. And the first session is 80 milligrams, and then the second is usually 120, and the third is 120. But there's a little bit of a negotiation between the therapist and patients if they want to stay at the 80 milligrams. And then there's 12 90-minute non-drug psychotherapy sessions. So there's 3 before the first MDMA session to prepare people, to build the therapeutic alliance, to help the therapist understand what the issues are of the patient. And then there's 3 integrative psychotherapy sessions after each day-long experimental session, so a total of 12. And then at 2 months is when we look at the outcome data and compare the 2 groups. So this is the therapy component. But then how it works, this is the statistics before. In the control group, we have therapy without MDMA, but these are severe, chronic, treatment-resistant people who, unlike many studies in PTSD, we enroll people who've previously attempted suicide. So a lot of those people are excluded from studies, but we feel we have to work with the hardest cases. Yeah, and so, yeah, because if you're doing it just for the easier cases, what are you really doing? So in phase 2, you'll see below, this was preparing for phase 3, 23% in the control group no longer had PTSD at the 2-month follow-up, but in phase 3, it was 32%. So what it shows is the therapy can be effective. And so if you get randomized to the therapy group, it's not that you're getting nothing. You're getting some support, but it works in 32% of the people. But when you add the MDMA, that's where you get up to 67% at the 2-month follow-up. 2/3 no longer have PTSD. And of the 1/3 that still has PTSD, a lot of them, around 2/3 of the remainder, have had what's called clinically significant reduction of PTSD symptoms. They still have PTSD, but their lives have been improved by a reduction in symptoms. And we've done the 12-month follow-up in phase 2 and showed that people still keep getting better on their own after the treatment is over. That's, I think, the most important thing for insurance coverage. It's labor-intensive at the beginning, but if it lasts and durable and people keep getting better, then I think we can persuade insurance companies to cover it. So just as a brief neuroscience, this is the last kind of how does it work. We know that PTSD changes your brain. If you have trauma that you've struggled with, you can't get over it, your brain has changed. And we've heard before today about the amygdala, where fear is processed. And you have a hyperactive amygdala. So memories of the trauma or sounds or any kind of triggers, your hyperactive amygdala, and you can't think as clearly because your prefrontal cortex, where you think logically, can sort things out, you've got diminished activity. And then in the hippocampus, where we store memories into long-term storage, there's reduced activity, so that the trauma feels like it's always about to keep happening, or it's right around the corner, or it's never really processed into the past. And what MDMA does is exactly the opposite. We've had people in our study say, PTSD changed my brain and MDMA changed it back. And the way that it works is that MDMA reduces activity in the amygdala. And I think that's the most important point, is that these memories that are linked to fear and emotions, like the fight or flight, that you don't respond in that same way. You have a reduced activity in the amygdala, and you have increased activity in the prefrontal cortex. So you can think logically. You have more time to think about what happened and to separate out triggers from this automatic response that it's the trauma. But very importantly, this connectivity between the amygdala and the hippocampus is increased with MDMA, so that these memories that seem like they're always still happening, you can finally process them and put them into long-term storage. And so that's where it can make durable effects from even a few experiences without daily medication. This is only MDMA a few times. So that's basically how we think it works.
Why does it work better than other treatments?
Well,
you think?
The first reason is this, it's combined with therapy. I think when we look at this idea of here's a medicine to solve your problems, you've got a biological problem, take this pill, you're not really dealing with the full person. And you're really not dealing with the issues, the core issues. So I think it works better because it's combined with therapy. It also works better because of this amygdala reduction in activity. I think that's a key factor, is that these traumatic memories that are overwhelming to people, they don't know how to really fully address them, and they suppress the symptoms. And so these MDMA really makes it so you can focus on the core issues. And the other reason that it's better is that it's not a daily medication. It's only meant to be given a few times. So the side effects that you have from SSRIs, which can be significant for some patients, there's very minimal acute side effects during the day that people take the MDMA, but that fades. And so then you're learning how to heal yourself without the drug. And I think that's the key part, is what we want to do is help people be more independent afterwards without being dependent on a daily drug, which is good for pharma profits, but that's not what we're after. We're after patient outcomes.
So, okay, speaking of patients, I want to hear what it's like to go through this. Haven't experimented with it myself, so I actually don't know. I'm curious, like, what does it feel like? Why are you so different now than before?
One, what does it feel like? It's honestly, you're laying there and you have two therapists, and coming from the military, don't go to the doc, that whole thing. Plus, I was abused as a child, and the therapist that the court ordered me to go see actually told my abuser rather than reporting it. So I had a very healthy distrust of therapists in general. But also, as Rick was saying, when you start talking about, traumatic events, I got blown up in a porta-john in Iraq. It's one of the crappiest places to get blown up, but I didn't choose it.
So to speak.
Exactly. And I was also a designated marksman with a Barrett 50 cal. And so when I came back, I'm glad they accepted people who attempted suicide, because within 60 days of returning it, I put a gun to my head and pulled the trigger. And a manufacturing issue with the ammunition is the reason I'm alive. And I'll tell you, my son was 10 years old when I entered the trial, after my final suicide attempt. And this therapy is entirely the reason that he has a father instead of a folded flag. But how does it feel? It feels like doing therapy while being hugged by everyone in the world who loves you in a bathtub full of puppies licking your face.
That sounds amazing.
It really is. And you know, I know that there's the connotations of the party drug and all of that, but you're going through all the worst trauma in your life, but your body's not betraying you. You're not having a panic attack. You're not freaking out. You don't become over emotional or completely shut your emotions down. You're able to stay in the moment and go back to those really bad places and process them. But the change is actually, it is very, you know, enduring, because I actually went through, I took my first MDMA dose exactly to the day 8 years after I came off active duty from Iraq, November 22nd, 2014. I took my last dose in March of 2015. I haven't done MDMA since. I've taken it 3 times in my entire life. I haven't felt the need to. I also, because the universe kind of likes to dump stuff on me, I had a gentleman drowned in the lake behind my house in Charleston, South Carolina. I dove in, pulled him out, did CPR for about 15 to 20 minutes till EMS arrived. I then, about a year later, had a gentleman shot. Yeah, he died. And then a year later, I had a gentleman who was shot in the chest in Charleston. You know, rendered aid again. I can't fix holes in hearts on the side of the road. But after talking to the police and rinsing his blood off, they're like, hey, you got to stick around and wait for the detectives to show up. I picked up the phone and I called Rick. And it's funny because he was actually on the phone with Michael Mithofer, one of the therapists who did my MDMA therapy. And Rick's like, hey, John, unless it's an emergency, I'm on the phone with Michael. Can I call you back in 30 minutes or an hour? I'm like, dude just got shot. He died in my arms. He goes, hold on, let me bring Michael on the line. And I did a 1-hour therapy session waiting for the detectives right there, without MDMA, without anything. But I started processing that trauma right then. And yeah, I went and saw a therapist and dealt with it and talked about it. But, you know, I still don't have PTSD. And actually, both when President Trump announced retiree recalls for COVID, I actually wrote a letter to the administration asking to be recalled to active duty to prove, because I was medically retired for PTSD, that I am fit to serve. And I've also sent the same letter to the Biden administration. This is life-changing. And if I'm not special. This doesn't just work for Navy SEALs and stuff like this. It works for everyone. As a matter of fact, most of the participants in our trials actually aren't veterans. They're victims of sexual assault. And the reason you hear about veterans mostly is because, you know, getting blown up isn't as embarrassing as being sexually assaulted, so I don't have an issue coming and talking. But this is a game changer. And it's bigger because it goes back to that core message that you said of hope. We are telling people that PTSD is a chronic lifelong mental illness that once acquired is your new normal, and it's not. It can be healed in 67% of people in 4 months like a broken bone. And I don't know anybody in the military or anywhere else that if they break their leg, say, no, I'm just gonna hobble along with it for the rest of my life. Once people understand, I mean, how many Navy SEALs, how many operators, how many people in the military currently serve with PTSD don't seek treatment because they're terrified of losing their career and all of this? When they realize it's like a broken bone, they can go do a treatment for 4 months and continue to serve. We're not going to have these problems. And it leads to interesting operational problems. What happens if you're on, say, an OBL raid and you have somebody have auditory flashbacks and hear gunfire or helicopters that aren't there? The whole mission went south. And this is something that can be very, very easily integrated into DoD, VA, regular healthcare.
And so, well, that leads to the next question. I mean, what are the barriers there? Because there's a stigma associated with psychedelics. Look, it really came on my radar about 6 months ago, right? You know, just right before I met you. So, what are the barriers? What needs to be solved here? How do you overcome that stigma?
Well, that's a very difficult question. I just want to add one thing from what John said, is that we had someone from PTSD from Vietnam in our studies and was able to get better. So this idea that you could be stuck for almost half a century and you can still get out of that kind of pain and trauma. So it's a real message of hope. But as far as what the barriers are, part of the issue is going to be how do we get insurance coverage? We've heard that before. Because it doesn't meet all the normal codes, it's therapy plus drug. That's going to be a challenge. Because it's not the drug treatment, one of the main barriers is that we have to train around 25,000 therapists just in the first 5 years. So we have a whole therapist training program. The other barrier, I'll say, is the war on drugs and prohibition, because that has led to people thinking, yes, these are illegal drugs also, and they've got no beneficial uses, and then there's been a resistance to permitting the research that shows benefits from these illegal drugs for the concern that that will send the wrong message. So I think that that's, fortunately, it's diminishing. The war on drugs is seen as counterproductive, violates our liberties, and so that's permitting more of this research to take place. I think the other fundamental thing people have to understand is that these drugs, they're tools. They're good or bad. I mean, you could take this drug in a recreational context, you can have trauma come up, and you could end up feeling worse off if you don't process the trauma. And we've had people call us, they've taken these drugs in recreational settings, they've remembered sexual assault, and they were with friends that were just out to party, and they didn't want to talk about it, and now months later they feel worse. So the stuff that they'd sort of buried so that they could accommodate living in the world, now it comes to the surface, you have to let it out. And so I think it's not inherently good. MDMA is not inherently good, it's not inherently bad, it's just a tool, and how you use it is what determines. And if people could understand that, and we think that for sure, like the surgeons, it's about the surgeon's knife. I mean, the knife is in the hands of a surgeon, that's life-saving. In the hands of a criminal, it can be deadly. So I think we have to get that understanding. And then the other barrier for us has been really trying to interest the Veterans Administration and the Department of Defense in trying to adopt this. And so that's been really slow. I started that in 19...
They gave us a hard no when we try it. It doesn't matter. I make laws, so we can make them do it. But yeah, I mean, there's resistance, obviously, and their letter of explanation was interesting. This is from the DoD. I think the VA might be more open. I mean, you tell me. Are they more open?
Well, the VA is starting to be more. I had this conversation with David Shulkin, who used to be the head of the VA, and he was like saying, "Rick, you're being so naive. You should give this whole thing up." He said the VA is designed to squash innovation. And I said, well,
it's a government bureaucracy. Like it is designed to squash.
But I told him that this will just make it more enjoyable for me to eventually when I tell you that the VA has adopted it. So we're about to start research. So as I said, I started in 1990 with various VAs. Every 5 years I'd try again. So we're about to start research at the Bronx VA with Rachel Yehuda. Bob Parsons, who's a billionaire donor, started GoDaddy's a Vietnam vet, and he had PTSD from Vietnam that psychedelics helped him to get over. And he's talked about this. He just gave a $5 million grant to the Bronx VA.
Back in Vietnam, they could take psychedelics all the time, right? Because it was the 60s? Is that just a bad joke? I don't know.
Well, he didn't do it then, no.
Actually, special operators used a lot of interesting psychedelic symbols when they were deployed to Vietnam.
Yeah, but he just did it recently. In any case, we're about also to start in the Loma Linda VA, and we hope to start research here in the Houston VA. Would be really good. And then one of the other big things that we're trying to do is group therapy. And so we're working with researchers at the Portland VA to try to start a group therapy.
Of course it's in Portland.
Yes.
Sorry, I can't help with these jokes. I mean, and then you're talking about group therapy. It sounds like a party.
Well,
all right.
Well, that's why we want to do it here in Houston.
Let's go. Let's keep it in Houston, all right? Let's keep it serious.
Yeah, but I think the other big part is that we've completed one phase 3 study, and we need to complete the second. So there should be an Operation Warp Speed for mental illness, but but we don't have that, and I think that's where the FDA is still looking at this as this is a illegal drug so far, and it was actually a therapy drug in the middle 70s to the early 80s, and actually it was in Dallas where it became ecstasy. So,
are you optimistic though about FDA approval?
I'm extremely optimistic. Okay. Yeah, extremely optimistic because.
But then the next barrier, and as we've learned from other speakers, it's it's not just the FDA, but a CMS as well, and getting it insured.
Yeah, I think that's the big issue. And we're also trying to demonstrate, we've done cost effectiveness studies on our phase 2 data. We're updating them with phase 3. It looks very, very cost effective. And so I think, yeah, insurance coverage and then training therapists will be barriers, and public education. So I think this forum that you're having here today is so helpful, because it's part of us telling the story so people it can become destigmatized. That's what we need.
Well, thank you guys so much for coming.
It's the same one Joe Rogan got as well.
All right. Were you on his show?
Yeah, just recently.
Oh, really? Oh, okay. I didn't know that. That's awesome.
That was the third time.
Very cool. Great. Big round of applause, guys. Thank you. Ladies and gentlemen, thank you for bearing with us. I think that was some really great presentations, some really amazing speakers, and just an incredible lineup. So you should sleep well tonight, knowing that there are good people trying to solve humanity's problems. I think that's the entire point of this, is the hope and science message. Thank you so much for coming. Thank you so much for being a part of this great event.